The nighttime pill that skyrockets senior stroke risk. You know, that little PM pill people keep on the nightstand. After 60, it quietly raises stroke risk, and it hides in tons of popular brands. The mistake that doubles risk often happens after 9 p.m., when timing flips how your heart, blood vessels, and oxygen are regulated. Neurologists and cardiologists warn about PM antihistamines and decongestants at night because the effects stack while you sleep. In the next few minutes, you'll learn which meds to watch, safer timing that protects your brain, and simple swaps that still help you sleep. Quick payoff, a 2-minute bedtime checklist you can use tonight. If this sounds like someone you love, share this now. Then let's fix the biggest mistake first. The big mistake most people make at night. Most people take a PM pill right at lights out without checking what's inside. The label promises sleep, so it feels harmless. But the sleepy ingredient in many PM products is a first-generation antihistamine with strong anticholinergic effects. That matters at night because your body needs to dip blood pressure, keep heart rhythm steady, and maintain oxygen. When you add a sedating anticholinergic at bedtime, you can disrupt all three. Here's the thing most people miss. During healthy sleep, your nervous system shifts toward rest and repair. Blood pressure typically drops 10 to 20%, heart rate variability increases, and breathing stabilizes. Sedating antihistamines slow brain activity, but they also blunt the cholinergic system that helps fine-tune blood pressure regulation and airway tone. The result can be less dipping, choppier rhythm control, and more fragmented sleep, so you wake groggy and less steady on your feet. Now, here's where many folks get a double hit. A lot of nighttime, cold, and flu products sneak in a decongestant, pseudoephedrine or phenylephrine. Those constrict blood vessels and raise blood pressure. So, you might be taking a sedative that dulls your protective reflexes, while a decongestant pushes your pressure up. That mismatch is a bad fit for bedtime, especially if you already treat hypertension or have sleep apnea risk. Pain plus sleep combos quietly stack risk too. The pain reliever is often plain acetaminophen, which is fine on its own when used correctly. But the PM add-on is the anticholinergic. Layer that with a nightcap or dehydration, and you multiply dizziness, morning confusion, and fall risk. I've seen people wake at 3 a.m., stumble to the bathroom, and nearly pass out, not from the pain med, but from the sedative anticholinergic effect, plus low fluids. Another overlooked problem is hidden duplicates. You might take an allergy pill with the same sedative, then a PM pain reliever, and maybe a nighttime cough syrup, all sharing diphenhydramine or doxylamine. Or you double up acetaminophen across products and exceed safe daily limits without realizing it. That's how people end up with liver risk from acetaminophen and anticholinergic side effects at the same time. If you remember nothing else, remember this. Bedtime is when your body should be coasting, not wrestling with mixed drug signals. Read the active ingredients. If it says diphenhydramine or doxylamine, or if the box lists sinus, congestion, or maximum strength, it's a red flag for night. There's a smarter way to manage pain and congestion without sabotaging your heart rhythm and oxygen while you sleep. Now, here's the specific pill most people never suspect. The culprit, nighttime antihistamines, diphenhydramine, doxylamine. When a box says PM, the drowsy effect usually comes from one of two first-generation antihistamines, diphenhydramine or doxylamine. They were designed for allergies decades ago, but they cross into the brain and strongly block acetylcholine. That's why they make you sleepy. The problem is that the same anticholinergic action also slows reflexes, blurs thinking, dries you out, and interferes with the nervous system that keeps blood pressure and heart rhythm steady overnight. Let me make the stakes clear. Older adults are more sensitive to anticholinergics because the brain has less acetylcholine reserve, the liver and kidneys clear drugs more slowly, and there's often a longer list of other medications on board. That's why the American Geriatric Society's beers criteria flags first-generation antihistamines as avoid in older adults except for severe allergic reactions. Note, when mentioning decades elsewhere, use the correct format, e.g. 1940s and 1960s. No apostrophe, no truncated digits. It's not about being anti-sleep. It's about risk stacking when your body is supposed to be in its most stable state. What exactly do these drugs do at night? First, they impair baroreflex sensitivity, the tiny moment-to-moment adjustments your body makes to keep blood pressure smooth. You want a clean dip in pressure during deep sleep. Anticholinergics can flatten heart rate variability and blunt that fine control. So pressure may sag unexpectedly when you stand, surge in light sleep, or fail to dip properly. Any of those patterns raises cardiovascular strain and makes morning dizziness or bathroom trip, near falls more likely. Second, they dry mucous membranes and relax smooth muscle in the upper airway. If you snore or have undiagnosed sleep apnea, that dryness and relaxation can worsen partial collapse of the airway. That means more oxygen drops, more sleep fragmentation, and more adrenaline surges to reopen the airway. Those surges are exactly what you don't want if you're trying to keep blood pressure, rhythm, and clot risk calm through the night. Third, they can unmask rhythm problems. The combination of reduced vagal tone, altered heart rate variability, and sleep-disordered breathing is a classic setup for atrial irritability. People describe waking with pounding, fluttering, or a skipping sensation after a PM night. Even if the episode passes, those bursts matter. Atrial fibrillation can start and stop in short runs and still allow clots to form. That's the stroke connection most people never hear about. Now let's connect this to everyday products. Diphenhydramine shows up as the main ingredient in Benadryl for allergies, ZzzQuil for sleep, and a long list of PM pain relievers like Tylenol PM and Advil PM. Doxylamine appears in some Unisom products and other nighttime formulas. The labels don't shout anticholinergic. They just promise nighttime relief or non-habit forming. For someone over 60, the habit you'll want to form is reading the active ingredients panel before bedtime. The other big issue is cognitive effects. In older adults, anticholinergics raise the risk of acute confusion, memory slips, daytime sedation, and slower reaction times. That means next morning balance problems, bathroom urgency without control, and trouble focusing. If you already take medications for bladder symptoms, anxiety, depression, IBS, or allergies, your total anticholinergic load might be high without you realizing it. The nighttime pill can be the straw that tips you into delirium or a fall. Here's a quick mental model to keep this simple. Think ABC: autonomic control, breathing stability, and cognition. Anticholinergics nudge all three in the wrong direction at night. Autonomic control, blunted baroreflex, and heart rate variability. Breathing stability, drier, laxer airway with more snoring and drops. Cognition, morning fog, confusion, slower reflexes. If one of those is already fragile for you, a PM antihistamine can turn a small problem into a dangerous one. A common pushback is, I've used it for years and I'm fine. Two thoughts. First, risk isn't a guarantee, it's probability. As we age, the margin for error narrows, and last year's fine can become this year's tumble or ER visit. Second, sleep that depends on anticholinergics isn't deep, restorative sleep. Many people feel groggy and unsteady, not refreshed. When they switch to safer routines and timing, they sleep fewer total minutes at first, but feel better and steadier by morning. So what should you do with allergies or a cold flare at night? Use daytime, second-generation antihistamines that don't have anticholinergic brain effects, and keep nighttime focused on non-drug congestion care. For sleep, build a routine that anchors your circadian rhythm instead of overriding it with sedation. And if you absolutely need a short-term sleep aid, talk with your clinician about options that don't carry a heavy anticholinergic load. One last naming trap to avoid. Brand families reuse names across different formulas. Unisom, for example, sells doxylamine tablets, but also melatonin blends. ZzzQuil has diphenhydramine liquids and melatonin gummies. The name doesn't tell you the ingredient. The active ingredient line does. Make that your rule every night, because here's the payoff. When you remove diphenhydramine and doxylamine from the bedtime mix, you protect your brain, your blood pressure pattern, and your heart rhythm while you sleep. But antihistamines aren't the only culprits after dark. Some nighttime cold combos quietly add a second risk that pushes pressure up when you're least aware. That's where many people get caught next. Hidden danger in cold and flu nighttime combos, pseudoephedrine/phenylephrine. Here's the twist most labels don't make obvious. Some nighttime cold and flu products blend a sedating antihistamine with a decongestant. The sedative tries to slow you down. The decongestant tightens blood vessels and nudges blood pressure up. That's a mixed message for your heart at the exact time your body should be easing into a low-pressure, steady rhythm night. Let me break down the decongestants. Pseudoephedrine is the classic oral decongestant. It's a vasoconstrictor, which means it squeezes blood vessels in your nose to reduce swelling, but it can also raise systemic blood pressure and heart rate. Phenylephrine is another one you'll see on boxes. It's less reliably effective for congestion, but it still has vasoconstrictor properties. Either way, the effect is stimulation, not relaxation. And that's a poor fit for bedtime if you're over 60 or you treat hypertension. Now think about the normal dipping pattern your blood pressure follows at night. You want a 10% to 20% drop. Decongestants can blunt or even reverse that dip. Add a sedating antihistamine that dulls your body's protective reflexes, and you've got higher pressure with slower reactions. That combo increases chances of nighttime surges, morning spikes, and rhythm irritability. If you also snore or have undiagnosed sleep apnea, those pressure swings stack with oxygen drops, exactly the environment that pushes stroke risk higher. Interactions make this trickier. If you're on beta blockers, ACE inhibitors, ARBs, calcium channel blockers, or diuretics, a decongestant can compete with your meds. It can also worsen urinary retention if you take prostate medications like tamsulosin or finasteride. And if you already use other stimulants, caffeine late in the day, some antidepressants, or certain migraine medicines, you can feel jittery, wired, or notice palpitations when you lie down. That's not just uncomfortable, it's a warning sign. Labels to watch are the ones that shout relief but whisper the ingredients. Words like sinus, congestion, maximum strength, and day/night packs are tip-offs. The day pack often contains a decongestant. Sometimes the night pack does too. Don't assume the moon and stars on the box mean it's pressure safe. Flip it over and read the active ingredient line. If you see pseudoephedrine or phenylephrine anywhere in the nighttime side, set it back. A lot of people ask, but I can't breathe at night. What am I supposed to do? Here's the shortcut nobody teaches on the box. Handle congestion locally, not systemically. Saline nasal spray or rinses shrink swelling by flushing mucus and allergens without touching your blood pressure. A cool mist humidifier keeps airways moist. A medically guided nasal steroid by day builds baseline control in allergy seasons. A menthol rub on the chest can give that open feeling without forcing your heart to work harder. Another move that helps fast: head elevation. 2 pillows can kink your neck and actually worsen airway collapse. Instead, raise the head of the bed by 4 to 6 inches or use a wedge pillow. That angle reduces nasal pooling and postnasal drip, so you're not mouth breathing all night. Combine that with a short, warm shower or steam inhalation 60 to 90 minutes before bed to loosen secretions. You'll get better airflow without the vascular squeeze. If cough is keeping you up, reach for non-stimulating options. Plain honey in warm water can soothe an irritated throat. For a dry cough, dextromethorphan can be considered, but avoid combo syrups that sneak in decongestants or sedating antihistamines. If reflux is part of your cough, finish dinner earlier, avoid late alcohol, and don't lie flat right after eating. That's often the real fix behind a mystery cough at midnight. One more hidden trap: brand families change ingredients by flavor, form, or season. The severe sinus nighttime gel cap might include phenylephrine, while the liquid version drops it. The only way to know is the active ingredient panel. Make it a habit to scan for diphenhydramine, doxylamine, pseudoephedrine, and phenylephrine. If any show up on the nighttime side, you've found the risk stack. I want to be clear, relief matters. You deserve a night where you can breathe and sleep. The reason I'm tough on these combos is that the short-term comfort can carry a hidden cardiovascular price, especially after 60. Systems that use to adapt easily don't have the same buffer. So shift the timing. If you truly need an oral decongestant, talk with your pharmacist and take it in the morning or early afternoon, not within 8 hours of bed. Do this tonight. Choose plain formulas. For pain, plain acetaminophen. For congestion, saline and humidity. For sleep, anchors and wind down cues. When you stop mixing a sedative with a blood pressure raiser after dark, your heart, vessels, and brain get the quiet night they're designed for. And that's the foundation for a safer, clearer morning. The arrhythmia link, atrial fibrillation, and stroke while you sleep. Nighttime is prime time for rhythm instability because your autonomic balance shifts and breathing patterns change. As you drift into deeper stages, vagal tone rises and blood pressure dips. That's normal. But if you layer sedating antihistamines, a decongestant earlier, or a nightcap, you can push the system toward irritability. The atria, the heart's top chambers, get twitchy. That's where atrial fibrillation tends to flare, often in brief, unnoticed bursts while you sleep. Here's the shortcut nobody teaches. AFib doesn't have to last long to matter. Even short, self-terminating runs can. Let blood swirl in the atria instead of flowing smoothly. Stasis promotes tiny clots, especially in the left atrial appendage. If a clot breaks loose and travels to the brain, stroke risk can shoot up within minutes to hours. That's why I woke up with a weird flutter story deserves attention, not a shrug. What pushes people over the edge at night? The trio we just talked about, sedating antihistamines, oral decongestants, and alcohol. Anticholinergics flatten heart rate variability. Decongestants increase sympathetic tone. Alcohol fragments sleep and worsens oxygen dips. Add snoring or undiagnosed sleep apnea, and you've built a rhythm irritant stack. Your heart spends the night toggling between slow and dry and fast and tight, instead of cruising steadily. That mismatch is the breeding ground for AFib. Now, you might be thinking, wouldn't I feel it? Sometimes. Palpitations, thumps, flutters, a racing or irregular beat are obvious clues. But many episodes are silent. The hint shows up the next day. You're unusually fatigued, foggy, or short of breath on simple tasks. Morning headaches, a dry mouth from mouth breathing, or a higher than usual blood pressure reading can be indirect flags. If you notice a pattern after PM nights, pay attention. Your body's giving you useful data. Let me show you exactly how to start a sensible check without overreacting. First, track symptoms and context for 2 weeks. Bedtime, any PM, or decongestant product. Alcohol, snoring notes from a partner, and morning pulse and blood pressure. You're looking for clusters, palpitations, or fog after certain ingredients, or late dosing. This record becomes gold in a clinic visit because it turns a vague concern into a clear pattern. Once you've got a pattern, ask your clinician about rhythm monitoring. A 24 to 48-hour Holter catches frequent episodes. If your symptoms are sporadic, a longer patch monitor, 7 to 14 days, raises the odds. Wearables can help start the conversation, but let a clinician confirm anything the watch flags. If AFib shows up, the next steps are about stroke prevention and rhythm control, not just symptom relief. Before we continue, you need to understand the two levers that change stroke risk fast: anticoagulation decisions and trigger removal. Your clinician uses a simple scoring system to judge stroke risk and may prescribe a blood thinner if your risk is high enough. At the same time, you take away the nighttime triggers, anticholinergics, decongestants, and late alcohol, and treat breathing issues like snoring or suspected apnea. That combo reduces both the fuel and the spark. Here's the part that separates beginners from pros: timing. Move any necessary stimulants to morning, skip anticholinergics within 8 hours of bed, and set a consistent wind down that protects steady breathing. Cool room, fewer night awakenings, and head elevation if congestion lingers. Most people feel a difference in a few nights. Fewer flutters, steadier mornings, better energy. Don't do what I did the first time I saw this pattern. I blamed stress and kept plowing ahead. A patient's 2-week log showed every PM night was followed by a higher morning pulse and a worse blood pressure. We cut the antihistamine, fixed the congestion locally, and the palpitations faded. No exotic tests, just removing the friction points. If you remember nothing else, remember this: AFib loves nighttime chaos. Keep your inputs calm and aligned. If palpitations, breathlessness, or chest discomfort wake you, sit up, breathe slowly, and check your pulse. If symptoms persist, get care. If they pass, still bring it up at your next visit and ask about monitoring. Timing matters more than you think. Here's the fix. Timing fix: when to take what and what to skip at night. Here's the rule that changes everything. Avoid anticholinergics and decongestants within 6 to 8 hours of bedtime. That buffer lets your nervous system settle, preserves your natural blood pressure dip, and keeps rhythm calmer. If a label lists diphenhydramine, doxylamine, pseudoephedrine, or phenylephrine, it doesn't belong in your evening window. Move anything stimulating to morning or lunchtime so the effect fades before you lie down. Pain first, because it's the most common reason people reach for PM. Use plain acetaminophen earlier in the evening, ideally with your last meal or within 2 to 3 hours of it. Skip the PM add-ons and skip alcohol. If pain peaks at bedtime, try a topical first: diclofenac gel for joints, lidocaine patches for nerve-type pain, menthol or capsaicin for that cooling or warming relief. Topicals act locally, so they don't scramble your brain's sleep control or your blood pressure pattern. For cough or congestion, shift dosing to daytime. If you truly need an oral decongestant, take it in the morning or early afternoon, never late. At night, favor non-stimulating aids. Saline rinse, a short steam session 60 to 90 minutes before bed, head of bed, elevation, and a cool mist humidifier. If allergies drive your symptoms, use a second-generation antihistamine during the day and a nasal steroid consistently. Those build control without sedating you at night. So what's okay 3 to 4 hours before bed? Plain acetaminophen if needed, magnesium glycinate with your evening meal if your clinician says it's appropriate, and your usual maintenance meds as prescribed. What should you skip entirely in that window? PM, labels, oral decongestants, alcohol nightcaps, and big caffeine sources. Also be careful with late heavy meals. They worsen reflux and cough, which then trigger late night fixes you're trying to avoid. Let me show you exactly how to talk with your pharmacist to get this right. Bring your actual products to the counter. Say, I'm avoiding anticholinergics and decongestants within 8 hours of bedtime. Which of these are safe at night? And what timing do you suggest? Ask them to flag duplicates of acetaminophen and any hidden sedatives. If you need a replacement, say, I want a plain version for pain and non-stimulating options for congestion. 2 minutes of ingredient coaching can save you months of poor sleep and scary mornings. Now, a quick timing map you can copy tonight. Morning, if congestion is severe, an oral decongestant after breakfast, then stop for the day. Midday, second-generation allergy med if needed. Late afternoon, schedule arthritis exercises, heat, or a short walk to ease stiffness. Early evening, plain acetaminophen with dinner if pain is expected. Apply topicals to the spots that typically ache at night. 3 hours before bed. Last fluids, light snack if you get hungry at night, and set medications for tomorrow. 1 hour before bed. Screens down, dim lights, cool the room, nasal rinse if congested, then elevate the head of the bed. The thing most people miss is that timing beats dosing for sleep safety. The same pill can be low risk at noon and high risk at 10 p.m. Because your body is wired to downshift at night, anything that dries, sedates, or squeezes blood vessels can knock those systems off balance. Give your nervous system a clear signal, gentle wind down, steady breathing, and no mixed drug messages. If you remember nothing else, remember this: no PM or decongestants after dinner. Choose plain versions. Move relief earlier. Let night be for recovery. Use your pharmacist as your co-pilot and set an 8-hour safety buffer. Once you nail that, everything else clicks. Your sleep feels calmer, your morning steadier, and your numbers cleaner. Next, we'll rebuild your nighttime routine with brain-safe alternatives that actually help you sleep. Safer sleep alternatives for older adults, non-drug first. Now let's rebuild your nights the safe way. No anticholinergics, no blood pressure surprises. Start with anchors that tell your body when to be awake and when to power down. First anchor, morning light. Get 10 to 20 minutes of outdoor light within an hour of waking, even on cloudy days. That resets your internal clock so melatonin rises naturally at night. Second anchor, a consistent wake time. Yes, even weekends. Wake time drives bedtime, not the other way around. Set up your room so sleep is the default. Cool it to the mid-60s if you can tolerate it, make it dark, and keep it quiet. If noise is an issue, use a simple fan or a soft white noise machine. Build wind-down cues that happen in the same order for 20 to 30 minutes. Dim lights, light stretching, a paper book, gentle music, or a brief mindfulness practice. Keep it boring on purpose. You're training your brain to link those cues with sleep. Let's talk magnesium glycinate versus melatonin, because people ask about these constantly. Magnesium glycinate can help with muscle relaxation and nighttime leg discomfort for some folks, and it's generally gentle on the stomach. If you use it, take it with your evening meal to avoid loose stools. Melatonin isn't a sedative, it's a timing signal. Low dose works best. Think 0.5 to 1 milligram, taken 2 to 3 hours before your target bedtime, not at lights out. Higher doses don't mean better sleep. They can cause morning grogginess or vivid dreams. When should you skip melatonin? If you have autoimmune conditions without your clinicians, okay. If you're already feeling groggy in the mornings, or if you're taking other sedating meds at night. Also avoid extra-strength blends that add antihistamines or multiple botanicals. If you trial melatonin, set a stop date, 2 to 4 weeks, to see if the timing nudge sticks. If it doesn't, pivot to behavioral fixes. Gentle behavioral tweaks add up fast. Use stimulus control. Bed is for sleep and intimacy only. If you can't sleep after 20 to 30 minutes, get up, keep lights low, and do a quiet activity until you feel drowsy, then return to bed. Shorten or eliminate evening naps. If you must nap, cap it at 20 minutes before 3 p.m. Limit evening fluids after dinner to reduce bathroom trips, but keep a small sip available if dry mouth wakes you. If pain drives your insomnia, handle it upstream so you don't reach for PM formulas. Try heat on stiff joints 30 to 60 minutes before bed, gentle range of motion stretches, and targeted topicals on the exact painful spot. A supportive pillow setup can unload pressure points, knee pillow for hips and back, or a small cervical pillow for neck alignment. The goal is comfort without sedation. Night cough or post-nasal drip. Go local, not systemic. Do a saline nasal rinse in the early evening, then follow with your prescribed nasal steroid if you use one. Run a cool mist humidifier to keep airways moist. Elevate the head of the bed by 4 to 6 inches to reduce drip and reflux. A simple throat-soothing routine, warm water with honey, can quiet irritation without stimulating your system. Food and movement matter more than most people think. Finish dinner at least 3 hours before bed, and keep it lighter at night. More protein and vegetables, fewer heavy fats, and late sweets that drive reflux and blood sugar spikes. A 10 to 15-minute easy walk after dinner helps digestion and lowers nighttime glucose, which also reduces nocturnal awakenings. Avoid vigorous workouts within 3 hours of bed. Save them for earlier. Caffeine and alcohol are landmines. Cut caffeine after lunchtime. It can linger for 6 to 8 hours and fragment sleep even if you fall right to sleep. Alcohol may make you drowsy, but it disrupts deep sleep and worsens snoring and oxygen drops. If you drink, keep it modest and early with food, and give yourself at least 4 hours before lights out. Create a repeatable closing routine. 30 minutes before bed, set tomorrow's meds, and a glass of water, dim lights, cool the room, and power down screens. If your mind races, try a quick brain dump. Write tomorrow's tasks on a notepad and close it. A brief breathing pattern like 4-6 breathing. Inhale 4 counts, exhale 6 for 2 to 3 minutes lowers arousal without medications. If you remember nothing else, remember this. Anchor your clock in the morning, protect your wind down at night, and treat symptoms locally. When you do that, you won't need a PM pill to force sleep. You'll nudge your brain to choose it. Nighttime pain, safer paths than PM labels. Let's clear up the biggest myth first. PM on a pain label doesn't mean stronger pain relief. It means the manufacturer added a sedating antihistamine, usually diphenhydramine, to plain acetaminophen or another painkiller. The pain control is the same. The extra sedation adds anticholinergic side effects that raise confusion, dizziness, urinary retention, and fall risk after 60. So, if pain is the reason you reach for a PM pill, you're paying an unnecessary safety tax. Here's the smarter move. Choose plain acetaminophen and time it earlier. If your pain tends to flare at night, take a scheduled dose with dinner, not at lights out. That keeps relief on board without the late anticholinergic hit. Read the active ingredient line. You want acetaminophen alone. Skip bottles that add diphenhydramine or doxylamine, and keep a running daily total so you stay within your clinician's guidance, especially if your liver is a concern. For arthritis, build a simple plan that spreads relief through the day. Warm up stiff joints late afternoon, 10 minutes of heat or a warm shower, then gentle range of motion movements. If your clinician allows, use plain acetaminophen with dinner and a topical right on the hot spot before bed. Scheduled light activity after dinner. A short walk can lower stiffness and make the nighttime dose work better. The key is routine, not rescue. Topicals are your best nighttime friends because they act locally, not systemically. Diclofenac gel for knees, hands, or small joints delivers anti-inflammatory effect to the surface tissue with far less whole body exposure. Apply with clean hands, let it dry, and avoid stacking with oral NSAIDs unless your clinician agrees. For nerve-type pain or tender areas, lidocaine patches can numb the spot for several hours. Menthol or capsaicin creams create a warming or cooling distraction that reduces pain signals without touching your heart rhythm or blood pressure. When should you avoid NSAIDs at night? If you have reflux, chronic kidney disease, uncontrolled hypertension, or you're on blood thinners, bedtime ibuprofen or naproxen can backfire. They can irritate your stomach, raise blood pressure, and interact with anticoagulants. If an NSAID is part of your plan, keep it earlier in the day with food and under medical guidance. At night, default to topicals and plain acetaminophen unless your clinician directs otherwise. Now, let's build a clean pain wind-down stack. Start 60 to 90 minutes before bed. Step 1. Heat on the stiff joint for 10 to 15 minutes to relax tissue. Step 2. Gentle stretches or a slow mobility routine. Think ankles, knees, hips, spine, no forcing. Step 3. Apply a topical to your specific pain point. Step 4. If needed, take plain acetaminophen with a small sip of water at least 1 hour before lights out. Step 5. Set up supportive pillows. Knee pillow for hip or back alignment, or a small roll under the neck to offload pressure points. This stack reduces the urge to chase pain with a sedative. If your pain wakes you at 2 a.m., don't add a PM pill. Sit up, breathe slowly, and do a 2-minute gentle movement, ankle pumps, shoulder rolls, or a brief hamstring stretch. Reposition with support pillows and use a topical on the spot. If you truly need an oral dose, use plain acetaminophen and keep it minimal. The goal is to settle pain without sabotaging your morning with anticholinergic fog. What about combination labels that promise nighttime relief for aches, congestion, and cough? For pain, they add nothing you can't do better with a targeted plan. You trade a small convenience for more risk. Keep your toolkit simple: plain pain med, local topicals, heat, movement, and position. Handle congestion locally with nasal care, so you're not tempted by decongestant sedative mixes. You'll wake clearer and steadier. One more practical tip: stage your pain plan before dinner. Put the topical by your bedside. Set the heat pack where you'll use it, and place a single plain acetaminophen dose in a small cup if you're likely to need it, so you won't go hunting for a PM bottle at midnight. This tiny bit of prep removes decision fatigue and protects you from last-minute, high-risk choices. If you remember nothing else, remember this: PM doesn't mean better pain control, it means unnecessary sedation. Use plain acetaminophen earlier, lean on topicals and heat, align your joints with pillows, and keep NSAIDs away from bedtime if you're at risk. You'll cut pain without inviting confusion, falls, or morning blood pressure spikes. Medication audit: spot and remove hidden anticholinergics. This is the step that protects everything you've built so far. Do a full medication sweep: prescriptions, over-the-counter products, vitamins, supplements, eye drops, creams as needed, pills, and anything you keep in a travel bag or nightstand. Put them on a table. Your goal is simple: find anticholinergics hiding in sleep, allergy, bladder, mood, and motion sickness categories, and find duplicates of acetaminophen. Start with sleep and allergy. Pull anything labeled PM, nighttime, sleep aid, or allergy relief. Flip to the active ingredients. If you see diphenhydramine or doxylamine, tag it with a sticky note. Those are first-generation antihistamines with a strong anticholinergic punch. Next, check cough and cold products, syrups, gel caps, and day/night packs. Tag anything listing diphenhydramine. While you're there, circle acetaminophen on any label so you can add up daily totals safely. Now skim bladder and GI products. Some overactive bladder meds and IBS antispasmodics carry anticholinergic effects. If a label mentions antispasmodic, antimuscarinic, or urinary urgency relief, tag it for review with your prescriber. Mood, nausea, and motion sickness categories can also sneak anticholinergics into your routine. Think meclizine or dimenhydrinate for vertigo or travel. These might be fine occasionally in the day, but they're not night-friendly. Create 4 piles. Pile 1. Keep at night. Maintenance prescriptions your clinician wants you to take in the evening. Pile 2. Safe by day only. Things that help but don't belong within 8 hours of bed, like oral decongestants. Pile 3. Replace Anticholinergics and PM products you'll swap for safer options. Pile 4. Question for your pharmacist or prescriber anything unclear, duplicates, and combinations that seem busy. Deprescribing is stepwise. Don't stop anything abruptly without guidance. Make a short list of the anticholinergic items you want to remove first, and note why you use each. For example, Tylenol PM for knee pain at night becomes plain acetaminophen with dinner plus diclofenac gel. Benadryl for allergies becomes second-generation daytime antihistamine plus nasal steroid. Bring this translation list to your clinician so you can agree on the plan and timing. Here's how to use your pharmacist in 5 minutes. Put the tagged items in a bag and say, I'm reducing my anticholinergic load and avoiding decongestants at night. Which of these should I stop? What plain versions replace them? And what's the safe timing? Ask them to scan for hidden acetaminophen so you don't exceed your daily limit, and to flag any interaction with blood pressure, prostate, or anticoagulant medications. Replace strategically. For allergies, favor non-sedating daytime antihistamines and consistent nasal steroids. For sleep, use non-drug anchors, and if needed, discuss a short trial of low-dose melatonin timed hours before bed. For pain, choose plain acetaminophen earlier and local topicals at night. For dizziness or nausea, ask about non-drug maneuvers first and reserve meclizine for specific daytime needs. The idea is to shift relief earlier and go local whenever possible. Track your progress for 2 weeks. Each night, note what you skipped, what you replaced, and how you felt the next morning, clarity, steadiness, bathroom trips, and blood pressure if you monitor. Most people notice fewer nighttime awakenings, less morning fog, and steadier balance within days of cutting anticholinergics. A quick warning about brand families. The same brand can contain completely different ingredients across lines. Melatonin here, diphenhydramine there. Treat every bottle like a new product. Read the active ingredient line, not the marketing on the front. If you remember nothing else, remember this: the audit is your safety lever. Identify anticholinergics. Replace them with plain or local options, time relief earlier, and bring your pharmacist and clinician into the loop. Do this once, and your nights get calmer and safer. Nocturnal blood pressure, the stroke predictor. Before we go further, you need to understand your silent night signal, blood pressure dipping. In healthy sleep, your average blood pressure falls about 10% to 20% compared to daytime. That dip gives your arteries and heart a break, lowers strain on small brain vessels, and sets you up for a smooth morning. When dipping doesn't happen, what clinicians call non-dipping, stroke risk, and cardiovascular events rise. The kicker? Nighttime meds that squeeze vessels or scramble autonomic control can flatten or reverse that dip. Here's why this matters so much after 60. Blood vessels get stiffer with age. Baroreflexes get less responsive, and many people add hypertension meds to the mix. Normally, that still allows a gentle overnight decline. But if you add decongestants, alcohol, or anticholinergic sedatives in the evening, you push against the body's dip. That can trigger nocturnal surges and a bigger morning spike, the time of day when strokes and heart events cluster. The thing most people miss is that normal clinic blood pressure doesn't guarantee safe nights. Your 2 p.m. reading can look great while your 2 a.m. pressures are elevated or erratic. That mismatch shows up as morning headaches, fog, or a high first reading despite good daytime control. If you've noticed tougher mornings after p.m. nights, that's your early warning sign. Let me show you exactly how to check this at home. For 2 weeks, take 2 readings each evening, 1 before dinner and 1 2 hours after. and 2 each morning, 1 within 30 minutes of waking, 1 after breakfast. Sit with feet on the floor, back supported, arm at heart level, and rest quietly for 5 minutes. Before measuring, use the same cuff each time. Log the numbers with notes about any nighttime products, alcohol, congestion, or poor sleep. Now look for patterns. You want evenings to be modest and mornings to be about 10% lower than your daytime averages. If your mornings are routinely equal to or higher than evenings, you may be a non-dipper. If you see big morning spikes, say 15 to 30 points higher than your typical daytime, check the prior evening's ingredients and timing. Many people catch a clear link between PM products or late decongestants and a bad morning profile. When your log shows suspicious patterns, ask your clinician about ambulatory blood pressure monitoring. That's a 24-hour cuff that records pressures every 15 to 30 minutes through day and night. It's the gold standard for diagnosing non-dipping, masked hypertension, and nocturnal spikes you'll never catch in clinic. If you're already on blood pressure medicine, this test can guide safer timing. Sometimes shifting a dose earlier or rebalancing classes smooths the overnight curve without adding pills. Here's the shortcut nobody teaches. Timing changes can beat dose increases. If you're taking a stimulating med late, move it to morning. If your blood pressure peaks in the early hours, your clinician might adjust when you take certain agents to cover that window. Never change your prescription timing on your own, but bring your 2-week log and ask, can we use this to match my meds to my pattern? Common mistakes to avoid: stacking sodium late in the day, heavy late dinners, and late alcohol all push morning pressure up. Dehydration can trick your body into holding fluid overnight and surging by morning. On the flip side, flooding fluids right before bed can disrupt sleep with bathroom trips and stress responses. Aim for steady water intake earlier and taper after dinner, leaving a small sip by the bed. Quick when you can try tonight: skip PM and decongestants after dinner. Elevate the head of the bed slightly, do a 10-minute easy walk after your evening meal, and take your first morning reading before coffee. Most people see a calmer morning number within a few days. If you remember nothing else, remember this: protect your night dip. Calm inputs at night, smart timing of meds with your clinician, and a simple 2-week log can reveal and fix the hidden blood pressure pattern that predicts stroke. Sleep apnea, snoring, and stroke risk multipliers. Let's pull the oxygen wildcard into the picture, because this is where nighttime risk can jump fast. Sedatives and anticholinergics dry and relax the upper airway. If you already snore, have a stuffy nose, or carry apnea risk, that extra dryness and relaxation can narrow the airway. Narrow airway means more resistance, more snoring, and more pauses. Each pause drops oxygen, the brain alarms, and your body surges adrenaline to reopen the airway. Those surges raise blood pressure and irritate heart rhythm. Exactly the opposite of the calm night you need. The thing most people miss is how often sleep apnea goes undiagnosed after 60. You don't have to be loud or overweight to have it. Hallmark signs: loud or frequent snoring, observed pauses or choking sounds at night, morning headaches, dry mouth, sore throat, restless sleep, getting up to urinate several times, and daytime fatigue or fog even after a full night in bed. If you wake with a racing pulse or a higher morning blood pressure, that can be an apnea clue too. Antihistamines can make this worse for some people by drying mucosa and thickening secretions. Drier tissue sticks, nasal passages narrow, and mouth breathing increases. Mouth breathing collapses the tongue base backward, which tightens the bottleneck. Add a congested night, and you've built a perfect storm for oxygen drops. That's why PM nights can feel disproportionately rough the next morning. Lighter sleep, higher blood pressure, and a heart that worked overtime. Before we continue, you need to understand why those oxygen dips matter for stroke. Repeated desaturations trigger blood vessel constriction, inflammation, and clotting tendencies. At the same time, arousal surges spike blood pressure and destabilize rhythm. That 1-2 punch stresses small brain vessels and can flip a vulnerable heart into an arrhythmia like atrial fibrillation. It's not just snoring, it's a nightly stress test on your brain and heart. Here's the shortcut nobody teaches on the cough and cold aisle. Treat airflow locally and positionally while you arrange proper testing. While you're waiting for a sleep evaluation, sleep on your side, elevate the head of the bed by 4 to 6 inches, and keep your nose clear. A saline rinse in the evening, followed by your clinician-recommended nasal steroid. If you use one, reduces swelling without stimulating your system. Run a cool mist humidifier to keep tissues from drying out. These small moves cut resistance and reduce oxygen dips. Simple screening can push the process forward. Ask your partner if they've noticed pauses, gasps, or loud snoring. If you live alone, note morning headaches, dry mouth, and unexplained daytime sleepiness. Bring this to your clinician and say, "I'm concerned about sleep apnea. Can we do a sleep study?" Home sleep testing is widely available and often enough to confirm obstructive apnea. If results are borderline or other conditions exist, an in-lab study gives more detail. If apnea is confirmed, treatment options are better than ever. Continuous positive airway pressure, CPAP, remains the gold standard and is far more comfortable with modern masks. For milder cases or CPAP-intolerant folks, mandibular advancement devices fitted by a dental sleep specialist can hold the jaw forward and open the airway. Weight management, if appropriate, reduces collapsibility. Positional therapy devices keep you off your back. The key is choosing a solution you'll actually use, because consistency protects your heart and brain. Now, common mistakes to avoid while you sort this out. Don't use PM antihistamines to force sleep through snoring. You'll blunt your arousal cues and allow longer oxygen drops. Don't take oral decongestants at night to open the nose. They raise blood pressure and won't fix the collapsible part of the airway. Don't rely on alcohol to quiet your mind. It relaxes throat muscles and fragments deep sleep. These feel helpful short-term, but undermine oxygen and rhythm stability. Quick wins you can try tonight. Side sleep. Elevate the head of your bed instead of stacking pillows. Do a saline rinse an hour before lights out, and keep humidity comfortable. If reflux is in the mix, night cough, sour taste, stop eating 3 hours before bed and raise the head of the bed to reduce microaspiration that inflames airways. You'll breathe steadier with fewer awakenings. If you remember nothing else, remember this: protect your oxygen, keep the airway moist and open locally, avoid sedatives that dry and relax it, and get tested if you spot the signs. When breathing stays steady, your blood pressure dips, your heart rhythm calms, and your brain gets the quiet night it needs. The 2-minute nightly checklist. Do this instead. Grab your products and your plan. This takes 2 minutes and protects your night. Step 1, scan labels. Anything that says PM, nighttime, sleep aid, sinus, congestion, or maximum strength gets flipped to the active ingredient line. If you spot diphenhydramine, doxylamine, pseudoephedrine, or phenylephrine, it's out for tonight. Replace pain products with plain acetaminophen only. Replace congestion, help with local care, saline, steam, and head elevation. Step 2, set your breathing. Do a gentle saline nasal rinse in the bathroom. If you use a clinician-recommended nasal steroid, take it now, not at lights out. Turn on a cool mist humidifier. Elevate the head of your bed by 4 to 6 inches, or use a wedge pillow. Don't stack pillows. This reduces post-nasal drip and reflux that trigger midnight coughing. Step 3, treat pain locally first. Apply a topical to the exact painful spot. Diclofenac gel for joints, lidocaine patch for nerve-type pain, or menthol/capsaicin cream for soothing distraction. Give it 5 to 10 minutes to set. If you still need oral relief, take plain acetaminophen with a small sip of water now, at least an hour before bed. Skip PM blends and skip alcohol. Step 4. Cue your clock. Dim lights. Set the room to the cool side. Power down screens. Do a short wind down ritual. Light stretches, a paper book, gentle music, or 2 minutes of 4-6 breathing. Keep it predictable and boring so your brain recognizes the pattern. If your mind races, write tomorrow's top 3 tasks on a note card and close it. Step 5. Stage tomorrow, remove temptations. Lay out your daytime meds and a glass of water on the counter for morning. Put any PM or nighttime labeled products back in a cabinet you won't open overnight. Place your plain acetaminophen and topical by the bed in case pain flares so you're not hunting risky combos at 2 a.m. Step 6. Hydration guardrails. Sip a half glass of water, now if you're dry. Then stop. Leave a small bottle on the nightstand for a single sip if you wake with dry mouth. You're preventing nighttime bathroom trips without getting dehydrated, which can worsen dizziness and morning numbers. Step 7. Congestion fallback. If your nose plugs up later, don't reach for an oral decongestant. Remist saline, reposition on your side, and re-elevate. A brief, slow inhale through the nose and long exhale through pursed lips calms the system. Honey in warm water can soothe an irritated throat. Keep it simple, non-stimulating, and local. Step 8. Safety signals. Set a gentle alarm for your usual wake time to stabilize your schedule. Place a small flashlight within reach for bathroom trips. If you stand at night, pause at the bedside. Ankle pump for 10 seconds and stand slowly to avoid a pressure drop and wobble. 2 final checks before lights out. 1. Confirm no PM, no oral decongestants, and no nightcap made it into your evening window. 2. Breathe easy. Your airway is prepped, your pain is local, your room is set, and your morning meds are staged. If you need extra sleep help after this checklist, that's your cue to talk with your clinician about a short, low-risk plan. Never default to anticholinergic sedation. Tonight, keep the inputs calm, keep relief plain and local, and let your heart, vessels, and brain settle into the quiet night they're designed for. When you truly need a sleep aid, safer paths with your doctor. Sometimes you've done the routine, fixed timing, treated pain locally, and you still can't fall or stay asleep. That's the time to plan a short, structured aid with your clinician, not a nightly habit. The goal is simple: help you sleep now, protect your brain, heart, and balance long-term, and step down as soon as your sleep stabilizes. Start with a low-dose, short-term melatonin strategy. Melatonin is a timing cue, not a knockout pill. The sweet spot for older adults is usually 0.5 to 1 milligram, taken 2 to 3 hours before your intended bedtime, not at lights out. That earlier timing nudges your internal clock without dragging you into morning fog. Skip extra strength and multi-ingredient blends. If you feel groggy in the morning, the dose is likely too high or too late. Set a stop date, 2 to 4 weeks, so you and your clinician can reassess whether it helped. Next, ask about cognitive behavioral therapy for insomnia or CBTI. This is the gold standard because it retrains your sleep system instead of sedating it. A good program tightens your time in bed to match sleepability, then expands as your efficiency improves. It also tackles the mental loops, worry, clock watching, what if thoughts that fuel insomnia. You can do CBTI with a clinician through validated apps or in small group programs. It's work, but the payoff lasts for years without medication side effects. If a prescription option is necessary, discuss ultra-low-dose doxepin, 3 to 6 milligrams at bedtime. At this dose, it primarily blocks histamine H1 receptors to help with sleep maintenance and has minimal anticholinergic effect compared with first-generation antihistamines. It's not a morning hangover drug when used correctly, but it can still cause grogginess in some people. So start low and monitor balance and alertness on rising. Avoid higher depression treatment doses for sleep. That's where anticholinergic effects increase. Now, a clear caution. Z drugs like zolpidem and isoprolol and benzodiazepines like temazepam or lorazepam raise fall risk, confusion, and next-day impairment in older adults. They can also worsen sleep-disordered breathing. If they're used at all, it should be under specialist guidance at the lowest effective dose for the shortest possible time with a defined exit plan. Never combine them with alcohol, opioids, or other sedatives. If you've been on one for months or years, talk with your clinician about a slow, supported taper rather than stopping abruptly. Build a stepwise plan with stop rules. Step 1, non-drug anchors and medical cleanup, pain plan, nasal care, reflux control. Step 2, low dose, early evening melatonin trial for 2 to 4 weeks. Step 3, add CBTI or a validated digital program. Step 4, if middle of the night awakenings persist, discuss low-dose doxepin as a temporary bridge while CBTI takes hold. Step 5, reassess every 2 to 4 weeks and remove whatever you can as sleep stabilizes. A few practical guardrails keep you safe. Take any sleep aid only when you can allow at least 7 hours in bed. Don't double up agents. No melatonin plus prescription sedatives plus antihistamines. Keep a small symptom log for your clinician. Sleep onset time, awakenings, morning steadiness, and any palpitations or breathing issues. If you notice morning confusion, near falls, urinary retention, or new constipation, stop the new agent and call your clinician. Ask your pharmacist to check interactions. Say, I'm considering low-dose melatonin or low-dose doxepin. Do either interact with my current meds, especially blood pressure, prostate, or anticoagulants? Have them scan your supplements too. Some sleep blends hide antihistamines or multiple sedatives. Keep it simple and single agent. If you remember nothing else, remember this. Use sleep aids as a ramp, not a residence. Nudge timing with tiny melatonin. Retrain sleep with CBTI. Consider low-dose doxepin if needed. And set a stop date. Protect clarity, balance, and breathing first. Red flags. Stop and call your doctor now. Here are the danger signs you don't wait on. This is about speed, not bravery. First, the fast stroke test in the morning or any time. Facial droop, arm weakness, or speech trouble. If any are present, call 911 immediately. Minutes matter because clot busting and other treatments are time-locked. Don't drive yourself. Activate emergency services right away. Nighttime red flags after a PM pill or a decongestant. Sudden palpitations that don't settle, dizziness when standing that nearly drops you, or a near fall on the way to the bathroom. If you feel faint, sit or lie down, elevate your feet, and seek urgent care. That combination can mean blood pressure swings, rhythm instability, or both. Morning confusion, new disorientation, or unusual agitation is another stop sign, especially if you took an antihistamine the night before. Add urinary retention, straining to start a stream, or severe constipation, and you've got a classic anticholinergic overload picture. Call your clinician the same day and do not take another dose. These symptoms raise fall risk and can spiral quickly. Blood pressure numbers deserve a hard line. If you see a single reading at or above 180/120, that's a hypertensive emergency threshold. Seek urgent evaluation now, even if you feel okay. If your morning systolic readings are 160 or higher on repeated days, contact your clinician promptly to adjust your plan. Bring your log. Patterns guide safer fixes. Chest pain, pressure, or tightness, especially if it radiates to the jaw, shoulder, or back, or new shortness of breath demands immediate care. Don't downplay it as anxiety or indigestion, particularly after a night with decongestants, alcohol, or sedatives. New ankle or leg swelling, unexpected weight gain over a couple of days, or waking breathless can signal fluid shifts or heart strain. Call your clinician the same day. New or worsening morning headaches, especially with a higher than usual blood pressure and dry mouth, can point to rough nights with oxygen dips or pressure spikes. If this shows up after PM or decongestant nights, stop those products and schedule a conversation about sleep apnea testing and medication timing. If the headache is the worst of your life, sudden, or with neurological symptoms, go to the ER. Any fall with a head bump, even if you feel fine, deserves attention. Sedatives and blood thinners make small bleeds dangerous. If you're on anticoagulation and you fall, get evaluated. Delayed symptoms can fool people. Don't gamble. Finally, if you're caring for someone and you notice new confusion, slowed responses, or unsteady walking after a night of PM, remove the suspect products and call their clinician. Bring the bottles. Hidden anticholinergics are often the culprit. If any of these red flags appear, stop the nighttime sedatives and decongestants, switch to plain local care only, and get medical guidance. You're not overreacting, you're preventing bigger problems. Key takeaway: skip nighttime anticholinergics and decongestants. Fix timing and use plain, local, and behavioral strategies so your heart, pressure, oxygen, and brain can stay calm overnight. If this helped, subscribe for practical senior health guides. Then watch my blood pressure morning routine to steady your numbers. Before you close this, do two things. 1, comment no PM after dinner to lock in your commitment. And 2, share this with a friend who keeps a PM bottle on the nightstand. They'll thank you tomorrow morning.